Alex,
Alex,
Andrés,
Andrés, Kevin, Claudio,
Sebastián Torres.
Physiologist, and I think everybody is known. Yeah? No,
Yes.
I don't forget anybody. Yes. Okay.
No.
So after this TAVI case, once again, I'd like to thank Dr. Cura for helping us with his experience with this device, which is quite new, I would say, in Argentina. Dr. Gustavo has prepared this case. We will present the slides and we will comment the case.
Thank you, Oscar. So
Will you
next
see there?
slide.
Yeah. Next.
This is a 69 years old patient with a mild ischemia, history risk factor for hypertension, dyslipidemia, hypothyroidism. He had an inferior ST myocardial infarction in June 2017 with a primary PCI in another center with a good clinical evolution. Then the patient continued asymptomatic with a negative stress test at the follow-up.
Next.
Next slide. The ECG showed us a sinus rhythm with a myocardial necrosis in inferior wall. The blood test is normal. The echocardiograph Doppler has preserved a low ejection fraction of left ventricles, 55%. And the echo stress showed us that the patient had angina and anterior ischemia with hypokinesia in this region. The next one, please. This is the angiography showing us a mild diffuse right coronary artery with a stent in the proximal and middle section of this artery without restenosis. The other one, please. Next slide. This is the left coronary artery with a mild stenosis in the circumflex artery and severe stenosis, moderate stenosis at the proximal LAD and the severe stenosis at the middle segment with a left with a first diagonal compromised.
Next.
This projection also showed us the same lesion we described before with a critical stenosis at the middle segment with first diagonal compromise. The other one, please. Next slide. So in summary, this is a 69 years old patient with a previous ST inferior myocardial infarction. Now the patient is asymptomatic with a severe LAD diagonal bifurcation stenosis with a Medina classification 011. The heart team's suggestions was LAD and diagonal PCI. Next one, please. So the strategy will be a radial access with a double kissing, double crushing technique guided by intravascular ultrasound.
Okay, perfect. That's it. Go back to the lab. So in summary, it's a young patient that did well after this primary PCI until this new positive stress echo, Gustavo, and that's why this patient underwent coronary angiography, which is not that usual to indicate an angiography on stable patients here in the clinical practice of the hospital. Is that correct? So
you are right.
Okay, perfect. And then you might
yes.
can describe what you have already done here.
Well, the radial access was performed by a 7th sheet. Then we choose an XB guidance catheter 7th French in order to perform the bifurcation we described before. And we reached, we can show the images. We reach a severe tortuosity at the subclavian and the previous one. Here we can see a severe tortuosity at the subclavian and brachiocephalic arteries, but we could reach the left vein without any problem.
So here probably we have to clarify something. First, when we are using 7 French, usually is for big males like him. First. Second, we normally use the radial set for the beginning, and then we exchange for the 7 French, not 7 from the beginning. Is that correct?
You are right. We after punching the radial R3, we put a 5 introducer sheet, and then we change it for a 7-1.
And third, when we advance the 7 sheath from radial, we normally put a long catheter like multipurpose or something like this to prevent any kind of damage of radial arteries. And this is the situation where you might have, some help to advance in this such a complex tortuous subclavian.
You are right.
Give me the torque. So the idea here is to put 2 wires, 2 regular wires, to predilate with a 2.0 balloon, and then probably do IVUS if we can. Yes. I think we have too much vent. Let's go to the diagonal with this. And then give me the other one.
Okay. Okay.
That is okay. When we use 2 wire, we usually bend the secondary branch
Wire
wire.
to perform the wire.
Yeah. Give me a second. We need a small bend because there is a quite straight vessel with a lot of branches before the lesion.
So in this case, you will predilate the LAD in order to perform the ultravascular ultrasound.
Yeah, I
study.
think if we can do this, it's gonna be better because we can decide which stent, give me the torque, which stent we can use. More rational decision using the IVUS.
Okay.
Probably I did now a very small vent. Let's test. Now we are better.
Do you think that intravascular ultrasound will change your strategy?
Probably not change the strategy, but would simplify, and we will help us to make better decisions about post dilatation, the stent size. We had to decide what to do with the proximal segment of the LAD.
Right.
Also,
Right.
that we don't know. I think it's moderate, but to be honest, I'm not strongly convinced. The
Which
tail
balloon
is a
would
little
like
bit low. Levántame un poquito la mesa. Give me the 2.0 balloon.
Okay. 2-0.
2-0. O 1. So why we have decided to use 2 stent strategy here? Well, this is a Medina 011. So it's a complex bifurcation with a very important side branch, probably irrigating more than 10% of the myocardial mass. So these branches should be at least protected. And if they have lesions longer than 10 millimeters, according to some meta-analysis published by Giuseppe Di Chida. I was reading there his name to pronounce properly in SHAC 2020. Let's go. He showed that 2-stent strategy using DK crash is better than than only 1 stent for this side branch with the significant lesion and long lesions. So here, now we have to predilate the diagonal very gently to prevent any kind of dissection. So the idea of 2-stent in this case is to use DK crash. We are familiar with the technique. Probably it's complex, but if you follow all the steps, probably it's gonna be smooth. For going, other strategy would be culotte here. A small branch. We will try to use less metal as we can in these
I-
small arteries.
in the DK crash trial, show that this technique is better than culotte stenting
Yeah.
with less TLR and MACE.
Okay, let's go there. Okay, perfect. Deflate. Little bit more ostial. Okay, let's go. Okay, that's it. So now, while Gustavo and I go with the IBUS, one can prepare a 3.0 short balloon or 20, can be 20.
Non-compliant or compliant?
No, can be compliant balloon. It's okay. Preparar el balón de 3020. Let's go with the IBUS. Which IBU have you prepared, Gustavo?
This is the Eagle from Vulcano.
Okay, so it's gonna be manual pullback.
No, it's automatic pullback, sorry.
Hold it.
Yeah.
Andres is prepared to see
To show
Yeah.
the image.
the imaging of the IBUS. I will try not to destroy.
Mhm.
Okay. Claudio is having me a clock in front of me so I can follow the time. So probably we'll have to rush a little bit. So as you can see, we have problem to cross. No. Okay. Let's go from there. May I help you? Yeah, let's go. Pull back.
Image.
Can we see the IBUS on the screen? Can
Yeah.
we change the configuration? Perfect. We see a small artery there. Forward, stop. Probably.
Boy.
Yeah. Perfect.
So we are performing the pullback from the distal segment LAD.
So there we have the vessel is 2 point something. Oh, now it's a
Yes.
little bit advanced. Let me pull back a little. There.
We have a severe calcification.
I would say
Circumflex.
fibrotic plaque there, no? And there is the
Yes.
calcium,
Yeah.
180 degrees in the plaque. The vessel there is approximately 3. And there is a very tight stenosis where we have problem to cross with the IBUS after the bifurcation. There is the ostium of the diagonal. There is the proximal segment of the LAD. You see the second wire. There, the lumen is okay. Gustavo, do you agree on that?
Yeah, you're right.
So calcification, but the area is okay except there.
It's there, yes.
Mhm.
It's more severe than we saw at the current angiography.
Okay. And we are near the ostium now. And there is the ostium. The left main is very short. So my plan would be, okay, that's it. Stop. I would say to do the bifurcation first, and then we can fix the proximal segment with a short balloon stent. Sorry, do you agree on that?
Yeah.
So give me the 2.5 balloon. I will pre-dilate a little bit more for not having any kind of problem because it's very calcified. Probably it's a lesion that protablator would have been an option. We have prepared, but we are late. Give me the 2.5.
Okay.
Déjalo ahí. Dame el.
So we prefer to
2.5.
pre-dilate the 2.5. Yes.
This is 3, I think. Oh no.
The 3.8. 2.2, dame el 2.5. El balón 2.5.
We'll pre-dilate post
Diagonal
and the ostium of the diagonal.
Okay.
And prepare
We'd like to pre-dilate the proximal segment of the lady.
No. I will fix first the diagonal.
Okay.
The bifurcation, and then I will deal with the proximal part of the LAD.
Okay.
Probably it's not so interesting. So we still have 40 minutes. We are okay.
At the IBUS, we saw a surface severe calcification and 360 area
Yes.
compromise.
So let's go to predilate there. 1 to 10. Dame otra gasita blanca de esas. Deflate. Let's go once again. Will you zoom one? ¿Puedo usar el otro campo? 3, 4, 5, 6. Sí, ahí, perfecto. Okay. Display. Sí, test, Gustavo. Let's do a little bit distal.
Okay.
There, 1, 2, 3, 4. Okay. Okay. Now we are going to predilate again the ostium of the diagonal. Stay connected with the deflator. Let me try not to mix the wires. Be careful with this. Rota Pro device was moving, which is ready, but not very tight. This is the diagonal, which is the wire which has a bend. And prepare a stent at 2.5 by 24 or something like this. 2.0 por 2524. Or algo parecido. We are prepared for this patient. Okay, ultra thin strut biodegradable polymer stent. Okay, let's go, Gustavo. 1, 2, 3, 4, 5, 7, 8. Okay, that's okay. Okay. Let's go with the stent.
So you're going to stand first the first diagonal?
Yes, and we put
And
a
you will
3.0 balloon for crashing from the LAD.
Okay.
There is a way of doing reverse crash when you are doing provisional. In this case, for example, if we use here as LAD-10 with provisional for the diagonal, and then we have problem, dissection, or whatever in the diagonal, we want to convert for the two stent technique, you can do in the reverse way. You can put the stent in the LAD, then you open the cell, you cross with the stent to the diagonal, leaving the stent in the LAD, a balloon, sorry, in the LAD, and after deployment of the stent in the diagonal, you crash it, and then you do pot and kissing. Give me the 3.0 balloon. I will prolapse no more than 2 millimeters. We need 2 deflators. Patient is quiet.
In these kind of cases, when would you like to predilate with cutting balloon or rotablator instead of balloon and stent?
This is an excellent question. Probably this would have been a good case because he has a lot of calcium in the distal part of the LAD after the diagonal. But, you know, we haven't done from the beginning. Probably it's not necessary now.
Okay.
So let me push the diagonal stent a little bit. No, I am wrong. This is the
this
stem.
one.
Okay. And now the balloon. And now test. Okay. I think we can go there.
Yeah.
Inflate the stent. 1, 2, 3, 4, 18.
18.
It's okay. Tape, guardar. Desinflar. Deflate.
Okay.
We are
Going to brush the stem
yeah, I have
with
to take
the
care with the
LED button.
guiding. Huge guiding, but it's moving. Not that easy to keep in the position.
Are you going to keep the wire?
Could you test?
Yes. Yes, of course.
Okay, diagonal is, let's do a cine.
Okay.
Test. Diagonal, I think it's perfect.
Yeah.
Now we are going to pull the balloon, and first we have to pull the wire.
Yeah.
We have the wire. Let's pull the wire. There. Okay. Crash it.
Yeah.
1, 14. It's okay. Perfect. Okay. So now I will
So you are going to recross.
I will try to pull the guiding a little bit. Try not to destroy the wire while pulling the balloon. If leaving the wire here in the sinus, I advance the guiding again. I am pulling the balloon. We can do ansio now.
Yeah.
Okay, I am out. Okay.
Yeah.
I'm not engaged. Okay, let me put the second wire in, and then we can reposition in the guiding. Let me yeah.
So you're going to recross the stem in the diagonal branch in order to perform another kissing.
Yeah, some people use
dilatation.
the pot here. I'm usually not doing that. Probably the wire is completely destroyed. So I don't know, we will have a successful maneuver. So let's do everything from the beginning. Take the wire out.
Yeah. Okay.
Let's put,
wire.
which is the LED balloon.
The 2.5. The 2.5.
3.0.
The 3.0 is the LED and the 2.5 is the diagonal.
Sacamos esto, que no tengo guía. Okay, perfect. And now I will advance the balloon so I can reposition in the
Another
guiding.
wire. Dame otra.
The balloon is very easy to cross. So let's pull the balloon out so we don't destroy the wire.
Okay.
No lo desconecte, déjalo ahí.
Okay.
And give me the wire. Okay. For all these cases, we usually use regular wires. Nothing special about that. Your workhorse wire. Then if we had to go for a different wire, well, it's according to each operator's discretion or preference. So, but normally I would rather like to go with the regular ones. Give me the rotate, the pin. We have to go to the LED first. The guiding is not perfectly engaged. That's why I have some problems.
Do you think that 2 stents is better than provisional in this kind of angulation, or for instance, the branch diameter insists on 2 stents or 1 stent?
It's not a too favorable situation, but it would be difficult to recover this diagonal if we are using only one or provisional and we have a complication with the diagonal branch. So that's why I would rather like to go with 2 stents from the beginning. I try to cross distal as much distal as I can. Give me the 2-0 balloon, probably a new one, because
A new one.
yeah,
Otro, 2-0.
not too much difficulties, but
no.
we'll see now when
2-0,
we have
balloon.
to reopen the cell. Or deja ese para, leave this for the next. Give me the 2-0, the old one. Yeah.
Okay.
So if we can cross with this and then with the 2.5, we can save one balloon for next when we are going to have to recross with 2 layers of stents.
And this kind of calcification, severe calcification, 360 circumferential area, would be suitable for a provisional balloon angioplasty, or?
No, I think severe calcified lesions are not that easy, and I think probably actually it's not the 300, because in the 300 you have to do something else, rotablator, cutting, scoring, or it's okay, or I mean probably lithotripsy.
Okay.
But in this case, which is 180, I think you can escape, but in not all the cases. Probably if we were in our regular days, I would have done rotablator.
Okay.
Let's give me the 2.5, one of the 2.5 that you have there. So we will sure that we are open the cell of the side branch stent. And then we have to decide which stent are going to put in the LAD. I think it should be 2.5. Then we can, I mean, post-dilate or to improve the position of the stent. I was guided, but the middle segment of the LAD is not that big for a 3.0. Do you agree on that?
Yeah. Andres is showing us the distal reference area.
Yeah. And how big is it, Andres?
3 millimeters.
It's
this
3
is
by IVOS.
Yes, but
Okay.
this is a
Deflate.
proximal
Well,
LAD.
But the distal is to the diagonal.
2.5.
2.5, yeah. Okay. So we will do an angio here, and we will decide which stent. Probably we can use the IVOS for measure the length, but we will estimate. Let me see.
Okay.
Give me a 2.5 by 30. Yeah. So we will go for the first septal branch or before until the second big distal branch with the 2.5.
Okay.
And then we will finish with the bifurcation, and then we will put the proximal stent. It's okay?
Yes, there's a big difference between luminal diameter.
Take this out, which is the balloon from the LAD.
Okay.
Give me a second. Always clean hands. Which problem we might have or face here if we cannot advance this stent due to the calcium, due to the protruding layer of the stent. So one potential solution would be, I was bringing the bad luck, probably. So, okay, pull it. Let's go out and let's go for a kissing stent. kissing balloon.
Kissing balloon.
Give me the 2.5 and the 3.0. But we have forgotten. And then we will go with the stent.
2.5, 3.0.
Which is this?
This is
2.5?
the 2.5, yes.
Okay. So probably when we open the cell, we push some layer of the stent into the LAD, and I forgotten to do the kissing while I was talking. Then if it doesn't work, we can go by pot. And then if it
3.0.
doesn't work, we can go with the balloon and we can advance guide extension. Tenete a mano un
Axilla.
Godzilla o el otro de Medtronic. Míralo. Ok. Bueno, inflalo. 1, 2, 3, 4, 5, 6.
LAD.
Sí, 7, 8, 9, 10. 10. Deflate. There is some resistance here to advance also the balloon. So it's a long procedure, a lot of steps. You have to be patient. Infla primero de LAD. 3, 4, 5, 6, 7, 8, 10, 12, 14. Okay. Listen again. Okay. Deflate. Okay. Let's try again. One is going to hold the 2.5 from the diagonal. Now it's going to hold the 3.0 from the LED. And then we will try with the stent again. We still have 20 minutes to go. Hopefully we can deploy the 2 stents and
The
do
stent?
the kissing. The stent?
The stent. The stent here. Where is the stent?
The 3.0
The 3.0.
stent
Sí, sí, ahí.
here. Here also. Okay. Toma, agarra esto. You know, it's not that easy to be
So this
online
is the
with so many devices. And this is so ultra thin. The stent sometimes it's not that easy to see when we don't have the lights, all the lights on, because if not, we have saturation with the camera. So now we have a perfect advancement of the stent. You can see that. Wait. Perfect test. I think the position is perfect. We have to retrieve the wire.
We have to put it less distally.
No.
No.
I like it there.
We have a, okay.
Okay, inflate. 14,
14.
16,
Yes.
deflate. Let me try if I can recross now doing this. Okay, I don't know. Let me go. We have a very unstable position with the guiding. Have destroyed the wire again. Give me the pin. Take this balloon out. The issue is the left main is so short. I don't want to be too deep pushing this 7 French guiding. When I lose the position, it's very difficult to re-engage because due to this tortuosity that Dr. Gustavo showed to us, it's very difficult to move this then. Let's pull the wire, let's reshape if we are lucky enough. If not, we will change it. ¿Tenete otra BM ahí a mano? Tenela, no me la des. Okay. No. Let's try once. We are living in Argentina. We have to do something to save any device that we can. Doing always the best for patients, but cheaper if you can. I think the wire is not in the proper shape for crossing the diagonal. Let me see if I am lucky enough. It must be there. No. Give me another wire. Okay. In case we cannot cross with these regular wires, we might use the Sion, the filter, or any other wire of these characteristics. Oh, sorry. This is a good demonstration of how much time we spend doing a complex PCI in comparison with doing a TAVI case. In a straightforward TAVI case, in less than 20 minutes, you are done. Dame rotador. Okay. Prepárate un balón 3-5 corto. So if I can cross, I will do pot. Okay, just to reopen this. Was almost there.
Yeah.
I need to be patient. Poneme un poquito de zoom. Okay. Patient is too big. That's why I don't have a very nice imaging. There could be. There is when
Yeah,
you're
right.
pray for the wire to go. And when the wire goes, you are happy. Okay. Now you might have the new 2.0 balloon that you have behind.
Yeah.
Remember, the one that we saved at the beginning. I will reshape the wire again. "15 minutes to go." Okay. So the other trial which we should mention is the definition trial. In the definition trial, with almost 650 patients, there was a significant improvement on TLR using decay crash in comparison with only 110. Dame 1.5 balón. So here I cannot cross. I had to insist with a smaller balloon and then to recross in a different place if it is not possible. This kind of procedure, of course, are time consuming, as I show you, and also resource consuming. So let's try again with a smaller balloon. Now, I think we are inflate, Gustavo. 1, 2, 3, 4, 5, 6, 7, 8, 10, 12.
Yes.
Deflate. Let me move. Okay, inflate and deflate again. High pressure, 20.
Yes.
Okay, deflate.
Mhm.
Give me the 2.0 again. And here is where we observe the additional difficulties by the calcium that Dr. Lev was mentioned, and also the angle of the bifurcation. Everything is worsening the situation for this crossing, which is probably the last difficult one that we have to do for this procedure. Done. Okay, leave it. And now it's time to pray that we cross like here. And now, yes, you can inflate, but give me that the 3.0 balloon again. 1, 2, 3, 4, 5, 6, 7, 8, deflate. And me buscaste 3.5 corto. Ok. Ah, esto es 3.5. Sí. Bueno, ok. Okay. Okay, we have problem to cross. Maybe we can advance the balloon again. There. Let's try again. Probably we have
Cross the wires.
crossed the wires or something like this. Let's do it the other way around. Inflate 1, 2, 3. Yeah.
This one.
Yeah. Deflate. If not, we are crossing with an O 2.5. Dame 2.5N o 2.5. Okay.
Perhaps wires are twisted.
Maybe, but I don't want to pull it.
Okay.
Just in case we have some prolapse or something of the stents there. The bifurcation is okay. Both vessels are okay. So we have just a matter of time preparing this bifurcation. Búscate un 2.5N. No lo abras, tenelo ahí. No lo sueltes, Gustavo.
No.
So my intention is we can do final kissing and we can do IBUS. Let's go, Gustavo, 1, 2, 3, 4, 5, 6, 7, 8, 12, 14.
14.
Deflate. 14. Dame el 3.0. Okay.
Yeah.
Deflate. Here is important for your colleagues who are helping you to have order behind you, because if not, with such amount of devices we have open, we might make some mistakes. So, let me see if we can cross with this. With a 2, okay, 2.5 is okay. Give me the 3.0. If not, we are going to use a new one.
Okay.
Should
Yeah.
go.
Tiene que tomar un 30N.
10 minutes to go. I don't want to disturb the audience, but I am checking for all the show, still the pending show I have here. So now it's okay. Let's do the both 1, 2, 3, 4, not 5. Which is yours?
3.0.
Okay, par 4.
4.
See, 10.
Okay. 10.
It's okay. Deflate both. I see if I can go a little bit further. If not, it's okay. Let me see. Stay quiet.
Okay.
There is what Gustavo was saying, the angulation of the diagonal,
Mhm.
the deep angulation down. I am pushing the wire a little bit.
I think that you took
Now
the
we are better. 1, 2, 3, 4, 5,
you took
8.
the right decision to perform this with 2 stands
Yeah,
because it will be very difficult to recruit with a provisional balloon.
absolutely. Okay, done. Okay, let's put everything out. Yes.
Mhm.
And let's do ancho. And
need
let's do
nitro?
IBUS. And let's see if we can deploy the proximal stent. Let's take out this.
Mhm. Okay.
Let's do prepare the IBUS. Well, the guiding, as already mentioned, is not in a good position. The table is not that comfortable for Gustavo, but the
Okay.
bifurcation is perfect now.
Yeah, this is the IBUS.
Let's see. I will do the LAD at least, and then I will fix the proximal part of the LAD. And then probably out of camera, I can do IBUS with the diagonal just in case. ¿Tiene firme? Se está moviendo, que se quede quietito, quietito. Por favor, no te distraigas. When procedures goes long, it's important that everybody stay connected with the procedure, not with the transmission. Quieto, por favor.
Juan,
Mano, teneme la mano, Juan. So we have resistance there. I don't know if I can advance the IBUS more. Because we have a lot of angle there. But anyway, we did a 3.0 inflation. I was not going there. Let me see how far I can go. No. Okay, let's once again.
Are you going to?
Móvemelo para acá adelante.
Okay.
Let's see if we can advance the distal tip a little bit more, but it's difficult. Okay. Let's fix the proximal part of the LAD. We have done 3.0 there, 18 atmospheres. Probably we can post-dilate distally to the bifurcation after deploy the proximal stent. ¿O tenés un 3.0 de alta presión corto? Dámelo. Let's try once. I will try not to touch the bifurcation, because there we have already done 3.0, 2.5 in a not bigger vessel, according to the IBUS pre. Anyway, it's difficult to cross with other tools. Let's go there. 1, 2, 3, 4, 5, 6, 7, 8.
Yeah.
Deflate. Something is wrong, still wrong there. And there, 1, 2, 3, 4, 5, 18.
18.
Yeah. Deflate. Okay, once again, 1, 2, 3, 4, 5, 18. Okay, deflate. 1, 2, 3, 4, 5, 4,
4.
18.
18.
Okay, that's it. We touched the carina. So anyway, we will have to retouch at the end of the procedure. Looks better, but there is a calcium protrusion there that probably is interfering with the crossing of the IBUS. Anyway, I like the image. Let's try once. We have chosen this IBUS and not the solid one, because this one has a lower profile. But anyway, you observe that it's not that easy to cross, but although the low profile, the pushability is not that good, and we have even some problem to cross with the balloons. So Gustavo is flashing. Okay, give me 1 minute if I can cross and show the
Yes.
echo if it is possible, and then I will say bye.
Yes, we have an image.
Let's go with IBUS for the bifurcation. You see a very good stem expansion. I will do it faster. Very good apposition. Perfect. There's the ostium of the LAD, which is the diagonal,
diagonal.
which is perfectly open. This is the stem in the LAD, is 3.5 or something like this. Now we are going to deploy a 3.5 stem before the bifurcation. Then we will do a final kissing and we are done. I will do the final angio. And I think for educational purpose, I think everything was completed. Perfect. Thank you so much. See you next week. Vamos con un 3-5.